This video is on pneumothorax. Pneumothorax is defined as a collection of air outside the lung but within the pleural cavity, and the lung is collapsed in these cases. There are three main types of pneumothorax, which are the closed pneumothorax, open pneumothorax, and tension pneumothorax. For closed pneumothorax, the pleural cavity pressure is less than the atmospheric pressure. Whereas for open pneumothorax, the second picture over here, the pleural cavity pressure is equal to the atmospheric pressure, and there is also an open wound. You can see there is air in the pleural space. For the third type is tension pneumothorax, where the pleural cavity pressure is more than the atmospheric pressure, and this causes the air in the pleural space to increase and also unable to escape. This is a more serious medical emergency, and the tension will cause mediastinal shift to the opposite side and also tracheal deviation to the opposite side. This requires immediate management. Here are some of the causes of pneumothorax. It is often spontaneous, especially in young and teen men, due to rupture of a subpleural bullae. Other causes include secondary causes, for example, secondary to lung diseases like asthma, COPD, tuberculosis, pneumonia, lung abscess, carcinoma, and many others. It can also be secondary to connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome. Other causes include trauma, either blunt or sharp injury to the chest, or iatrogenic causes like subclavian CVP line insertion, pleural aspiration or biopsy, positive pressure ventilation, and sometimes liver biopsy can also accidentally cause pneumothorax. For clinical features of pneumothorax, the patient complains of sudden onset of dyspnea, which means sudden onset of difficulty in breathing, pleuritic chest pain, and also for those patients who have existing asthma or COPD, they may present with a sudden deterioration. Also, for mechanically ventilated patients, they may present with hypoxia or an increase in ventilation pressures. The signs of pneumothorax. There are signs which can be detected on palpation. For example, if it is tension pneumothorax, we'll palpate the tracheal deviation, deviating away from the affected side. There will also be reduced chest expansion. On percussion, it will be hyperresonance to percussion, and also on auscultation, there is reduced breath sounds on the affected side. For investigations, we can do arterial blood gas analysis and also chest x-ray, which is the definitive investigation. So for example, in this picture over here, this shows a right-sided simple pneumothorax. There is no mediastinum shift, no tracheal deviation, so less likely to be tension pneumothorax. And to suggest for pneumothorax, there is hyperlucency of the right lung. And if you see where the white arrows are pointing, there is the pleural line of the lung. There is collapse of lung. Moving on to management. Pneumothorax due to trauma or mechanical ventilation will require a chest drain. And the management we can do is aspiration of the pneumothorax or insertion of chest drain. So let's take a look at the more detailed management guideline of pneumothorax. This is for primary and secondary pneumothorax. So for primary pneumothorax, does the patient have shortness of breath? And or the rim of air is more than 2 cm on the chest x-ray? If yes, we do aspiration of the pneumothorax. If no, we can consider for discharge. So if we went for aspiration, if it is not successful, we consider to repeat the aspiration. And if still not successful, we can do chest drain for the patient. For secondary pneumothorax, we see whether there is shortness of breath, age more than 50, and also the rim of air more than 2 cm on the chest x-ray. If yes, we can do chest drain. If no, can consider for aspiration, and after successful, admit for 24 hours for monitoring. This is for simple pneumothorax. Tension pneumothorax will require other management, which I did not include in this video. That's all for this video. Thank you.